Welcome to Fertility Factor Fiction. I am your host, Dr. Rahi Victory, and tonight we are going to learn about whether or not your progesterone level should be higher if you're doing a frozen embryo transfer and you have endometriosis. So the reason for this requires a little bit of explanation. So let's go through some basic information that you need to know. What is endometriosis? Endometriosis is when the cells from inside your uterus actually jump and go into your pelvis or any other place. And so it is what we call ectopic or out of place location of cells from the inside of the uterus to somewhere outside of the uterus. Why is it a problem? It's a problem because patients with endometriosis have a much higher risk of immune activation. And because their immune system is overactive, it can cause scarring, it can cause pain, it can make it harder to just have sex. It can cause a lot of inflammation leading to immunological reasons why your fertility actually just isn't functioning properly because your immune system can be interfering. At least that's the theory behind some of it. And then, of course, there's the whole physical aspect of it where it can cause scarring, damage, blockage of your fallopian tubes, cysts in your ovaries, reduction of your AMH and your ovarian reserve. So that's kind of the what is it and the how it affects people. How many people are affected? They say up to 25% of women will have endometriosis, possibly even more in a population of fertility patients. So again, very prevalent, very common. So what's happening at the microscopic level? Well, we know that patients with endometriosis have altered receptivity in their endometrium, and that they have altered receptivity because the progesterone receptors don't work the same way as in somebody that does not have endometriosis. So the amount of estrogen and progesterone that's going through your system doesn't necessarily translate into the same outcome when you have endometriosis versus when you don't have endometriosis. So in theory, what these authors thought about was that based on the basic science information that was available, it's very likely that patients that have endometriosis require more progesterone because they're not as receptive to the progesterone. The receptors aren't working properly. They're not accepting the progesterone and processing it properly. What happens if we give them more? So interestingly, the background to this is really important. There are studies that definitely show that if you don't have enough progesterone, you're actually going to fail. And that's been pretty clear for a long time, which is why we poke and prod all of you with either vaginal progesterone or progesterone in oil or both. So that's been known for forever, like pretty much forever in the fertility world. And we've been doing that for a very long time. So because of that, we all are using progesterone or progesterones to help support your pregnancy. But then there are studies that say there may be too high a level as well. And there's argument as to what that level is. Some people say somewhere in the mid 60s for nanomoles per liter. Some people say under 100 for nanomoles per liter. Those are the Canadian units. 100 translates to roughly 30 something in the American nanograms per mil. So the question here was, what happens if we go above that threshold? What if we go over 100 and see what happens there? So this is how they got to this study. Tarek and I are just going to share our screen once that's available. So interesting just from the title. So number one, it tells you off the hop, you're going to do better if you have higher progesterone levels. So that the story is out there already. You guys can start asking questions about that. Number two, this is in hormone replacement therapy cycles. So keep in mind that virtually everyone out there hopefully now recognizes that the traditional frozen embryo transfer approach, where you give people estrogen and then you give them progesterone, is a terrible idea, resulting in far less success than the alternatives, which are natural, or letrozole, which is even better. So this doesn't necessarily apply to what everybody is doing. Now it might, and you may be able to carry this on, but it also may not. The other part of it is that it's a cohort study. So this was not a randomized controlled trial. So they followed people and then monitored what their progesterone levels were like, and then they reported it. That's great, but it's not as good as saying, hey, This group with endo just take this much progesterone, and this group with endo, you take that much progesterone, and let's see what the actual differences are. And we're going to randomly assign you so we don't get to be picky and send the better patients to one group and the worst patients to the other. So it's missing a few kind of finesse to it there, but it's at least some information, and it's kind of valuable for what they've done. So total, they had 262 frozen embryo transfers from 179 patients. About 2/3 of them got pregnant after one try. About 1/3 of them needed a second or more tries. So some other interesting tidbits to how they did it, because I disagree with a lot of this methodology. And if you watch the show, you'll know why we disagree with it. So all patients were pre-treated with 6 weeks of oral contraceptive pills. Not unreasonable if you have endometriosis. Why? Because we know for sure that the birth control pill is reasonable at suppressing endometriosis. And if you can suppress the endometriosis, that's probably going to be helpful. Hopefully, a lot of you watched my reel on Instagram where I said that lunatic that was claiming that the birth control pill causes depression and suicide was wrong. That is categorically incorrect. There is good systematic review evidence demonstrating that the birth control pill does not cause depression or suicide, especially amongst adolescents. So I took that data and think that that's important. But in terms of this specific area, there is benefit to taking the birth control pill because it will quiet the endometriosis. However, if you follow a little further into it, and I'll blow it up for you here, they then had 5 days washout and then did 6 milligrams of oral estradiol valerate. And that was done once daily. So they're giving people the full estrogen exposure. The whole point of trying to suppress people's endo is to avoid exposing them to estrogen. So why would you give these people estrogen? I don't know. It doesn't make a lot of sense to me, but this is the old protocol. That's what they do in hormone replacement therapy cycles. So I get why. An ultrasound was done after 12 to 19 days. Seems like a really long time, but nevertheless, they let it go for that long. And once they got to an endometrial thickness of 7 millimeters, they said, okay, we're going to start the progesterone. The progesterone was done with crinone, 90 milligrams every 12 hours, administered vaginally. And then on the 4th day, they also started using injectable progesterone. This is really cool because this is a European study. It's actually out of Denmark, where I just was on the weekend. And they don't use progesterone in oil in Europe. So this was kind of shocking to me, and I did appreciate that part of it. And then the rest of it is just what they did afterwards. Not quite as important, but bottom line is that was kind of how things were done. They did do a progesterone level after they had patients on the progesterone in oil and the vaginal. Okay, so let's go over to the data. And this is actually going to be quick tonight. We're going to leave you guys lots of time to ask questions about anything that you like. So I'll blow this up. Actually, maybe if I go this way, because then I can blow it up a bit bigger. Okay, can you see that? Yeah. Okay, so as I said, 262 frozen embryo transfers and 179 patients. So obviously the serum progesterone levels in the progesterone less than 118 group was much lower, on average 79.8. In the over 118 group, it was 150. So way, way higher. So they use this arbitrary cutoff. They must have developed a statistical curve, what's called an ROC curve. They found the cutoff point, it must have been 118. And then they use that 118 to then go back and examine the data to see how people did. So obviously in the greater than 118 group, it was really high. Like I personally would lose my mind if my patient's progesterone was 150, because that's a high progesterone level. That's like getting to birth control progesterone levels. So this is a lot. Whereas in the other group, it's kind of our target. That's really where we're hoping to be, in that 60, 70, 80 range. So that was a nice level there. Age, no difference. Body mass index, no difference. Keep in mind, these are relatively thin or borderline thin people. So most of them are pretty healthy. They did have some smokers, but thankfully not many. Usually European studies, everybody's smoking, so that was good. No other statistically significant differences till you get down to day of vitrification. So in the progesterone less than 118, 71% of the patients had day 5 blastocysts, 29% were in the greater than 118 for day 5 blastocysts. With the day 6 blastocysts, 51% of those patients had a less than 118, 49% had a greater than 118. Now that also may be related to the duration of exposure, but they actually made everybody transfer after 5 days, whereas for a day 6 embryo, we actually recommend you put it in after 6 completed days of progesterone. So again, another little glitch in the study there. Okay, where's the most important part? It's the part I've highlighted for you at the bottom, right? So the pregnancy rate per embryo transfer, they had a total of 60%, and 56% were, or I guess they had an average of 60%. So 56% were in the progesterone less than 118 group, and 69% were in the group that were over 118. So the group that was over 118 had this 13% higher pregnancy rate, and that per embryo transfer, and that's a lot. And all of the patients in this study had been confirmed to have endometriosis by surgery. So this is a very kind of valuable data set to look at. Implantation rate, 40% in the less than 118 versus 52% in the over 118. That's a big number. I mean, when you're 12% higher, that's getting close to almost 30% of the lower group. So you're getting a 30% boost in the number of pregnancies that you're achieving. That's a lot. So that's something that's very, very significant to consider. Live birth rate, which is obviously the holy grail, 34% in the group that's 118, but it's 51% in the group that's over 118. Now, the reason this is so critical is we know that endo patients get their success rates cut in half usually. In this study, they're actually almost normalizing their success rates. I mean, obviously, we have a higher rate than 51% for live birth, but these are really, really good numbers. Like, you don't normally find studies where 51% of the patients in the study were able to actually deliver a live baby when they had endometriosis. So this is suggesting that when you get these higher levels of progesterone, even as high as 150, you can actually increase the chances that you're going to achieve a live birth. And please remember, and look at this carefully, the units are really important. Whoops. We are talking about nanomoles per liter. You can see it right there. We are not talking about nanograms per mil. If you had 118 nanograms per mil, you'd probably be asleep because it would work like a sedative. They then went into it a little bit more in detail, and they wanted to evaluate what factors affected this. So you do that in something called the logistic regression analysis. So they, put in all of the confounding variables. They adjusted for body mass index, age, blastocyst age, which is day 5 or day 6, blastocyst quality, which is hugely important, and even number of blastocysts transferred. So that's also important. It's particularly important because if they didn't standardize it to just one embryo, that would also alter where the results are coming from. So this helps with that. So the group that had serum progesterone concentration over 118 had a 110% increase in the success rates after they controlled for all the confounding variables. That's what 2.10 means. So over double the success rate for live birth. This is huge, 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 right? We can't get that with anything else in an endo patient. So is this a game changer? Yes, this is a game changer. We will be adjusting our progesterone levels in our endo patients to go higher. Did the body mass index make a difference? No, it did not. Age? Yes. So the older you are, the lower your chances were of success by about 7%. Day 6 blastocysts did not have a difference compared to day 5 blastocysts. So that's also really interesting here. The blastocyst score did not make a difference, and the number of blastocysts transferred, whether it was the double or the single, it actually didn't make a difference either. So why is this important? This is important because I've never seen any study anywhere that can demonstrate a 100% increase in your live birth rate with IVF for anything we do with endometriosis. Our Lupron and Letrozole protocol won't get you a 100% increase. Doing surgical treatment won't get you a 100% increase. Taking all the supplements that we use will not get you a 100% increase. But this little tiny tweak of giving you a little more progesterone may be the key to success. And for me, that's huge. Would I like to see this done in a better trial? Yes. Am I willing to try and take a look at that and see if we can do that here? Definitely yes. But ultimately, this is super important as at least a starting point to see if this data can bear out and help us to help those patients with endo. So if you're suffering with endo, if that's part of your fertility journey and you need something done, you need to talk to your doctor about making sure they are maintaining the right level of progesterone for you. So is it a fact or a fiction that patients with endo need a higher dose of progesterone for their frozen embryo transfer? If you're doing a hormone replacement therapy cycle, yes, it is a fact. It appears that you do. You can get nearly double the success rate. So thank you for joining us for Fertility Fact or Fiction. We always appreciate you guys being here. Make sure you click the like button and subscribe if you're on YouTube, or follow us on Instagram and Facebook and Twitter. And now we're going to take your questions live.